The very mind-boggling session of renal vascular hypertension, now systemic hypertension session. Most common drugs, calcium channel blockers. I think it has been used in quintals. If you so, it's such a common prescription in day-to-day life. But particularly the advancement of the various type of calcium channel blocker and basic regarding the receptors on the vascular, whether in the myocardium, whether in the AV node, whether in the SA nodes, what are the generations, first generation, second generation CCB, third, fourth. So lot of queries, new advancement and the basics, pharmacological kinetics. These are our topics, and scientific committee have chosen a very relevant is CCB is all. And for all this topic, the speaker is not one of the top senior most cardiologist of the city, very soft spoken, good friend of mine, always mentor to all. Thank you, sir. You start your talk regarding CCP. I hope in afternoon all of you will enjoy and have attention for another 20 minutes and then 5 minutes on discussion.
Thank you, respected chairperson. Thank you, my dear friends. Good afternoon, everybody. The subject has been well summarized. Now, we all know that there are lots of types of calcium channel blockers, and these are ubiquitous. All the cells of the body have got calcium channel blockers, calcium channels, and different types of calcium channel blockers get attached to different kinds of channels and activate or deactivate them depending upon the situation. And as we know, depending on the property of the calcium channel blocker as well as the calcium channel, it could be as very selective vascular smooth muscle dilator, as for example amlodipine, and as our chairperson was commenting, depending upon the generation also. And also it could be affecting the cardiomyocytes as well as the conducting tissue to some extent, as in case of verapamil, diltiazem, etc. So there are different properties attributed to different calcium channel blocker, and they belong to different class of molecules. Now another type of classification is what is the kind of activation mechanism that is taking place, for example, voltage dependent, receptor operated, etc. And also depending upon the subtypes of the subunits. So there could be various types of calcium channel blockers. Now, one practical classification is L-type calcium channel, and they are distributed widely, particularly in the smooth muscle, including skeletal muscle and ventricular myocytes. For our purpose of this afternoon, I am skipping 2 or 3, but N-type is very important, and they are distributed throughout the brain and peripheral nervous system. That is why they are called neural type, and if they are modified, neural activity will be changing. Is it 10 minutes or what's the time? Okay. R-type in the different neurons, and T-type, again an important, particularly they are very important when we are considering the kidney, adrenal gland, etc., as well as the pacemaker cells. Now, with the advent of newer drugs, they are blocking different types of calcium channels at the same time. Initially, they were mainly involved with the L-type, as we see in case of nifedipine and amlodipine. Now, with the newer advents, they, along with the L, block N or T like that. So these become newer and newer and with different properties. So as we see, 3 or 4 things are multiplying. There are different kinds of molecules. Their molecular structure is different. They are getting into at the different sites. They are getting distributed in different channels, and ultimately different channels are getting blocked. Depending upon these, properties differ. It's not required. So, we know the calcium channels, when activated, lead to some detrimental effects, which could be vasoconstriction in case of L-type, sympathetic activation in type of N-type, and the vessels heart or kidney may be affected depending upon the activation. So if these are blocked, beneficial effects ensue. Similarly, if we activate the T-type, that leads to hyperactivation of the myocardium, leads to increased rate and risk of arrhythmia. The adrenal cortex is activated, and there is synthesis and secretion of aldosterone and rise in blood pressure. Again, in the kidney, they can lead to detrimental injury of the kidney, including vasoconstriction, which leads to intraglomerular hypertension, proteinuria, etc. So calcium channel blockers basically were first introduced about 35 years ago initially for coronary artery disease, but soon get wide recognition for their efficacy in hypertension. And that is the main indication nowadays, hypertension, particularly when it is affecting organs of different types, it becomes a consideration. And also for the prevention of the organ damage, it becomes a consideration. And the initial indication besides hypertension also included angina, peripheral vascular disease, and some arrhythmic condition. Again, in some arrhythmic condition, we keep these drugs like PSBT reservation, verapamil, diltiazem, etc. But for the angina itself, we can still use different types of calcium channel blockers, including amlodipine, ephonidipine, etc. So you get a large number of calcium channel blockers nowadays, but we cannot focus into each and every topic in this short space of time. So it will be naturally, as we have divided into different groups, they are having different action, they are not same. Now we will be comparing a few of this group, dihydropyridines, whether amongst them there could be certain differences in different calcium channel blocker like amlodipine, ephonidipine, etc. Now, the classification of antihypertensive CCBs according to predominant channels activity we have. So, predominant L-type blocker is nicardipine, nifedipine, and amlodipine. Out of this, amlodipine is the most used one. The L and T-type, the common blocker, they are coming out, and particularly this ephonidipine has become popular amongst them. And L and N type of blocker till now is very popular amongst the nephrologists, as we see with different, and in cilnidipine is a class effect for that. Nifedipine, we know, was initially very much successful in reducing blood pressure, but the short action, it led to some detrimental effect. So only the longer acting formulation should be used nowadays. Amlodipine has got many properties, you all know in details about them. I am not going into all the details, but one very important thing that they have got very long half-life, and that leads to smooth control of blood pressure for 24 hours, and even the BP before the next day's dose is well controlled, as also as BP variability is decreased due to the long half-life and smooth release pattern. So it is well established armamentarium in the treatment of hypertension. The doses you know, bioavailability you know, slow rate of elimination we have discussed, but most commonly reported adverse effect hindering compliance with amlodipine is peripheral edema, and that becomes a limiting factor at times. Then we usually look into the other types of calcium channel blocker, including ephonidipine, and as we see that with the different types of blocking, if the L's are blocked, the contractility is reduced, pulse rate is increased, and glomerular pressure is increased. That can be a problem because the imbalance between the afferent and efferent arteriolar constriction. Again, when the T-type is blocked, the balance between the relaxation of afferent and efferent is restored. So glomerular pressure as a whole decreases and proteinuria decreases. And in case of N-type, again, this probability remains, but unfortunately, there is some imbalance still residue as the relaxation between the afferent and afferent relaxation is somewhat better or more compared to efferent. That leads to some still residual intracranial hypertension. So effect of antihypertensive agents on cardiovascular events have been studied in different trials and reports, and particularly importantly, it has been discussed with amlodipine. There has been lots of trials reports are available. I'll just quote a few of them. So administration of amlodipine to patients with coronary artery disease and normal blood pressure resulted in reduced adverse cardiovascular event. So that was a landmark trial that was published in 2004. Again, when the PREVENT trial was published, it showed that amlodipine has no demonstrable effect on angiographic protection of coronary atherosclerosis or the risk of major cardiovascular event, but it is associated with fewer hospitalization for unstable angina and revascularization. And it also has a significant effect in slowing the 36-month progression of carotid artery atherosclerosis. So this now documents there are certain anti-atherosclerotic property with amlodipine as well, or calcium channel blocker in general. Now, all that is well established. It has shown the important place of calcium channel blocker, particularly amlodipine, in the field of hypertension therapy. And so, just we can conclude by saying that regarding amlodipine, to estimate the cardiovascular effects of amlodipine, traditional fixed effect meta-analyses were performed using data from 11 clinical large trials involving a large number of patients of 36,000 of amlodipine and compared to 53,000 of randomized. So almost you get the result of 80,000. And from our practical experience, we have nowadays experience of lakhs and crores of patients that have been treated by amlodipine. So it is well established now. Cilnidipine story, you know, I am just skipping, but it is a good agent as far as renal protection is concerned. But again, the problem remains that with cilnidipine, as we know, the afferent and efferent are both are arterial, dilated, proteinuria is reduced, but efferent is dilated to some extent, less compared to afferent. Some imbalance remains. And it has got less potency compared to amlodipine in the field of lowering of blood pressure. So the urinary protein to creatinine ratio significantly decreased in cilnidipine compared to the amlodipine group. This is an advantage. Now this pair of slides, this and the subsequent one, are very important as they have compared some of the important calcium channel blockers that are now available. So in this column you find that amlodipine has got a very long half-life and that leads to major disadvantages. T-type channel selectivity is found with eponidipine. That has got again major effects, particularly that affects the angiotensin-aldosterone system and also the conduction tissue of the heart. So this has got certain different property. And if we go into the negative chronotropy where reflex tachycardia, plasma renin activity, plasma endosterol remission, then the balance, as I was talking repeatedly about the balance of the afferent and efferent arterial dilatation, the equally balanced efferent-afferent dilatation is found in case of eponidipine, whereas the efferent are also dilated, but there is some imbalance with the other three, leading to either about proteinuria, kidney damage, etc. So if we think, at least theoretically, the maximum renal protection is likely to be had from eponidipine. And not only that, renal protective action is also obtained from reduced glomerular capillary pressure and eGFR is increased. Pedal edema again is the least with eponidipine, and use in angina is recommended in amlodipine and eponidipine, but not with the others. Effect of insulin resistance again is lowered by eponidipine, but no such metabolic effect is documented by other cancers. This again, calcium the cardiovascular index again is reduced. This shows that stiffness of the arteries is decreased to some extent. This is the dosage equivalent. So we can judge the dosage equivalent of this. Should I continue or what's the matter with the time? So we have got many effects obtained with the traditional calcium channel blockers, but with certain reservations. Traditional calcium blockers are potent antihypertensive agents as documented. They are favored in the management of hypertension as monotherapy or combination. Different types of combination is possible. However, still gaps remain in the therapy of traditional CCBs in terms of end organ protection and incidence of distressing adverse effects. So, as far as organ protection is concerned, there are some reservations with different calcium channel blockers, including cardioprotection, renal protection, inadequate vascular protection, and distressing side effects, particularly peripheral edema, constipation, flushing, and tachycardia. So we are looking into the better and better calcium channel blockers, which will be having more organ protective activity, which will be having more tissue protective activity, which will be having outcome activity, and at the same time, the documentation is obtained, and the less of side effect. So, activation of the sympathetic nervous system we have shown that leads to detrimental effects. So, blockade of the sympathetic nervous system, particularly N-type blockade, leads to certain advantage, that is prevention of reflex tachycardia, and also better preservation of the autonomic balance. But conventional CCBs has got a problem. As in case of kidney, we are seeing an imbalance between the afferent and efferent. So in the peripheral tissues, particularly in the ankle, there is some imbalance between the dilatation of the arterioles, pre-sphincteric and after the sphincter, post-sphincteric, and dilatation of the venues. If these arteries are dilated and venues are not dilated concomitantly, there will be leakage of fluid and accumulation of edema. This happens with nifedipine, amlodipine, etc. With newer agents, not only these side of the arteries, precapillary arteries are dilated, postcapillary venues are also dilated, so the excess fluid is drained and there is less accumulation of tissue fluid. Detrimental effect on renal function, we have talked about the balance several times, I'm not going to repeat, but with ifenadipine, if some time is permitted to tell me, then I'll show you the ifenadipine has got rid of these problems. This is the new generation of dihydropyridine CCB, and it has been discovered and introduced in Japan. Nowadays it is approved in India as well. The particular important thing is ifenadipine prevents blocks, dual T and L type of channel blockers. These T-type blockers leads to certain beneficial effect, that is negative chronotropic effect, no reflex tachycardia, reduces myocardial oxygen demand, so it becomes useful in angina. And the renoprotective effect is due to reduction in the glomerular hypertension, as we have shown you, reduction of the aldosterone secretion, this is an additional property of this molecule, and reduction of renin secretion, again an additional property of this molecule. This also improves endothelial function and arterial stiffness and better side effect profile by reduction of different side effects. So these are the different mechanisms of the better effect of ifenadipine. I'm not going to the details of each one, but what we find that it has got renoprotection better than others, and this is due to multiple type of calcium channel blocker, and ultimately that leads to effect in the vasorelaxation, decrease in fibrosis and apoptosis due to anti-inflammatory effect as well as anti-aldosterone effect as well as anti-renin effect, and ultimately all lead to better effect as far as the tissue and organ protection is concerned, and that is effective not only into the kidney, but as we can see into the other studies, into the heart also. So it has got certain anti-inflammatory effect in addition. This is important to remember. This is the balance, I'm skipping again, and the reduction in renin secretion with ifenadipine is an additional factor. So if you compare with the others, there is reduction of the plasma renin activity, reduction of the plasma aldosterone activity. So ultimate effect is enhanced renal and cardiac protection and enhanced vascular protection as well. So this is enhanced cardiac protection. This shows the some effect upon the calcium and sodium channel similar to ivabradine, and that reduces to reduction of the heart rate. This reduction to, as ivabradine is effective in angina, this also becomes effective in angina. Besides that, there is coronary artery dilatation is also there. The anti-arrhythmic effect and enhanced vasoprotection is there. Anti-atherogenic effect is there, similar to amlodipine. This cerebroprotective effect again could be of some importance to the neurologist. There is significant reduction of blood pressure, preferential dilatation of basilar artery, reduces risk of stroke, MI, and sudden death, improves regional blood flow in the brain, cortical, hippocampus, so may improve the cognitive function as well. So insulin resistance we are talking about may be beneficial, more effective in the diabetic state. In this setting, one may say, when there is diabetes is advanced and there is some neuronal damage, the N-type of blockage may not be that much effective, but this molecule still remains effective because its mechanism of action is different, so it may be effective in neuropathy, diabetic nephropathy, still maintained. So if you are talking about the side effects, constipation is less, flushing is less, palpitation is less, and edema is less. Pharmacokinetics wise, people may criticize that this has got less long half-life, and that may lead to certain detrimental effect. But that is counteracted by other factors like high lipophilic penetrates into the tissue better, strong membrane binding remains into the tissues for a longer time, and slow dissociation time from the channels again keep them for a longer time. So long effect remains, though the half-life is less. So tissue half-life is more. Equivalent doses, you know, I'm skipping. And epinephrine in patients population, be careful in the geriatric, use at a lower dose. Pregnant women, lactation not documented. Pediatric usage not documented. Hepatic impairment, if it is advanced, start at a lower dose. Renal impairment, no dosage is required. Multiple guidelines as vouched for it, including Japanese Society for Hypertension of Outline. So all them recommended this new molecule, and you can also try. There are Indian clinical trials. I'm not going up into the details, but they have again shown the benefit. Only criticism against them is the smaller numbers, but larger number is available in the international trial, and that has again shown the benefit in the elderly. Duration remains for a long time, and the different organ protection have been documented by different trials. Particularly JATO's trial is important from that point. So the take-home points are the different calcium channel blocker differ in their property. Epinephrine, the upcoming new molecule, has got excellent BP control, superior renoprotective action, enhanced cardioprotective action, superior vascular protection, unique antiplatelet activity and improving insulin resistance, unmatched safety profile, less incidence of pedal edema. Only criticism is that it requires longer duration of documentation in larger population. Thank you very much for the patient hearing.
Thank you, Professor Biswas, for excellent coverage of the subject. It's a unique that we have been supplied with so many calcium channel blockers since long period of time. Amlodipine is the gold standard because of widespread vasodilatation, its effectiveness in reducing blood pressure, and documentation over very, very large meta-analysis over consuming more than 15 trials all over the world. But it's true that we have to always try to improve. And it's because it is a Japanese molecule. Way back in 2008, in JETOS study, it was found to be excellent antihypertensive drug. But it came to the market much later, particularly because it is a Japanese molecule. It has not been accepted by the USA, which is the main driver of the pharmaceutical practice, even in India. So with these few words, let me request all of you to ask questions or your valuable comment to enrich all of us about the topic newer calcium channel blockers. We do have Professor Arup Biswas in front of us to clarify our confusions. Any questions or comments?
Any regarding, sir, hydropyridine ring and non-hydropyridine ring.
Yes.
Non-hydropyridine ring particularly for CCB for hypertension, angina, arrhythmia. So hypertension part we have so many advancement. Regarding the non-hydropyridine, particularly for diltiazem and verapamil, what are the advancement you are thinking? Because this is also common.
No. With the diltiazem and verapamil, we do not expect any more advantage.
Yeah.
The advantages have already been documented, whatever little is there. But with the newer molecules in newer classes may come up in near future, including in this group, in this molecular group, but that is required for the newer molecules, not with those.
So
These have been already documented. And one important area you have raised, we are always intrigued by different, lack of appropriate medication in the field of arrhythmia. That is always a problem of ours.
Yeah.
Non-hypertensive kidney disease.
Non-hypertensive?
Kidney disease. CKD, there are plenty of groups where
Yes,
CKD having no
accepted.
hypertension.
One is, usual combination is CKD and hypertension, but even when the pressure is not raised, this group can be used to decrease proteinuria, but doses should be lower. And not only in CKD, you raised a very important issue, in CAD also, coronary artery disease also, if the BP is well taken care of, this group can be used for reduction of angina as well.
Another
Yes.
thing we are just having in the thing, that the control of BP is not adequate with newer calcium channel blocker as the amlodipine as such.
No, you require usually a higher dose. The dosage equivalence is higher with the newer ones. Absolutely correct.
And regarding angina, particularly the fringe metal angina, vasospasm is there.
Yes.
Always drug of choice is your diltiazem or this. And second part is regarding the newer particular iflodipine, whether LNT, both receptor, there are some promising, lot of promise, although we don't have our own real-time data, but this is a promising drug in
Yes.
future. That is a part.
What is another very interesting issue is that we do harbor a huge number of diabetes, pre-diabetes and people suffering from insulin resistance. So thereby, a drug which effectively controls blood pressure without increment of the heart rate and without side effects like constipation and pedal edema, which are there with amlodipine. Proportionate dosage of ephonidipine, which has been shown to be 5 milligram, is comparable to 10 milligram of ephonidipine, has been found to be quite effective in the Asian populations, and that may be practiced as alluded by Professor Biswas very extensively.
If you give me 30 seconds, I'll explain one of
yes.
my patients.
Yes.
She is elderly, having mild CKD, was having severe hypertension which was not well controlled, as well as angina. I had to switch over from another calcium channel blocker to ephonidipine, raised to drug dosage to 80. With that, not only the angina was controlled, BP was better controlled, and the metabolic profile increased.
So it's a very, very unique welcome agent for all of us to make our practice a bit different in suitable percentage of our patients where we encounter certain problems as mentioned by Professor Biswas. And let me request all of you on behalf of myself and my co-chairperson Dr. Jha to give a big hand to Professor Biswas.
Thank you. Thank you.
Okay, thank you, Dr. Biswas. I would now request the chairpersons to hand over the memento to the speaker.